Hello, thanks for joining us. I'm Professor Sigmund Silber from Cardiology Practice and Hospital in Munich, Germany, and I'm very happy and delighted that Neil Uren, the Clinical Director of Cardiac Services at Edinburgh Heart Centre at the Royal Infirmary of Edinburgh, UK, joined us. Neil, thanks. You are going to present a complex case with a lot of discussions we will have and questions for the audience. Please show us the case.
Thank you, Sigmund. So I'd like to present a 77-year-old male who was visiting our city and arrived at our railway station with a history of recent onset worsening angina. He'd had an inferior STEMI back in 2001 when he lived in our city, and at that time had been treated with thrombolysis and declined any further invasive investigation. He had left our city after that and lived abroad and had been looked after well. And then when he presented to us, he actually gave a history over 72 hours of worsening pain on minimal exertion and ultimately at rest. And as he came off the train at a railway station, developed a sustained episode of chest pain for around an hour. He was also treated with furosemide in the context of mild LV systolic impairment. He was on metformin for his diabetes, and he was on a fibrate in the context of his hypertriglyceridemia.
Neil, may I ask questions regarding to the drugs? Well, it's not the key point of the case now, but since we are showing this slide, he's not on a statin. Why?
No, it's unusual. Well, we asked him why he was not on a statin, and he said it was because he had tried several statins and he was intolerant of them. He had myalgia. His cardiologist took the view as he was diabetic and he had a significant hypertriglyceridemia, and that his cholesterol level was acceptable at around 5 millimoles per litre or 200 milligrams per deciliter, that it was reasonable for him to be on a fibrate. He did not have any evidence of left ventricular failure. His 12-lead ECG confirmed extensive ST depression anterolaterally, and interestingly he had evidence of an old inferior MI with persistent ST elevation in his inferior leads, which we understood to be old as we did not have his previous case records available. The most interesting thing in terms of his presentation and concerns about how we managed his case were that he had evidence of renal impairment. He had a reduced EGFR significantly, and when he came for his 12-hour troponin I test, he had evidence of a non-ST segment elevation MI. So,
do we know, since it's my role to ask questions, do we know whether this ST depression is new or old?
Well, we didn't have an old ECG. He did have some dynamic change to his ST depression insofar as it would change. So it suggested that the anterolateral ST segment changes were the new problem and that the inferior ST elevation was pre-existing. So standard treatment in our centre would be to give a clopidogrel load. Because he had some ongoing discomfort when he first presented through the ER, we put him on a nitrate infusion. And because of his renal impairment, our choice of 2B3A would be a small molecule tirofiban, is what we usually use. And we gave him standard dose bolus and infusion of tirofiban because of his instability.
Well, this is interesting because this we would probably have done different way. Clopidogrel in these days in acute coronary syndromes, which is clear an ACS case. What about the alternatives? Prasugrel, he's diabetic, or ticagrelor instead of clopidogrel and tirofiban?
Sure. Well, I guess in our institution, our standard practice is clopidogrel. We usually reserve prasugrel for patients who have documented intolerance to clopidogrel or have documented resistance to clopidogrel, and we also use it in patients who have stent thrombosis. But as yet, our protocols don't mandate the use of prasugrel in diabetics. I guess that's something for us to consider as the guidelines envelop. So basically, the right coronary artery was shot first. We do almost all our procedures from the right radial route, and that includes non-STEMIs, primary PCI. And so he was done from the right radial route. And as you can see, his right coronary artery was an occluded vessel. This was obviously consistent with his history of an inferior STEMI 10 years previously, and we assumed this was a chronic occlusion. So we moved to his left coronary artery assessment. As you can see, he has a large circumflex system with severe disease both in the proximal and midsection of circumflex and also down into the distal circumflex, subtending a large second obtuse marginal branch. As you can see here, there's a large septal branch which is providing collaterals to his distal right coronary artery, but he effectively has occlusion in the mid-segment of his LED. There's a small, high diagonal branch. You can see there's some slow filling of a second diagonal branch there after the occlusion point.
Any data on ventricular function?
Yes, we did an echo on him, and he had evidence of basically severe inferior akinesis consistent with previous inferior MI.
We have a really complex case. It's an NSTEMI. We have an occluded right, an occluded LAD, and a severe stenosis in the circumflex territory. And how would you treat this patient?
Well, he was an unstable patient. The evidence base would suggest that he should be revascularized. We suspected the LAD was the culprit because it looked occluded in terms of recent occlusion with a slower flow into diagonal branch. Again, we had no information about the distal LAD, and so we took the view that we would proceed to percutaneous coronary intervention.
This brings us to the next question, and maybe we should consider the guidelines, the ESC guidelines on myocardial revascularization. Actually, this gives us a lot of options here, and option A is to treat only the circumflex, which we agree is not the culprit lesion. Or would you rather treat the culprit lesion, the LAD? Would you treat both lesions in one setting, the culprit and the non-culprit, with the non-culprit first or with the culprit first? Or would you treat both lesions but in separate settings as a staged procedure? I'm very excited to hear what you did.
Well, we use the guidelines as our directive almost all the time we practice coronary intervention. In this situation, we really felt that although the LAD was likely to be culprit, the circumflex was a big vessel. Although it had diffuse disease and long stretches of disease in it, we felt that if we got the circumflex back to normal and gave him one very good artery, supplying a substantive area of myocardium, it would just give us a little bit more support when it came to intervention in the LAD, particularly as we didn't really know the quality of the distal LAD. We didn't know how well it would open up or whether we would get it open up. And what we didn't want to do is perhaps try very hard to open up LAD and give this patient with renal function lots of dye and then still not be any further forward. So really quite different to normal practice, I took the decision that we would treat the circumflex first, and if that went well, which we hoped it would, we would then proceed to the LAD at the same time.
Well, guidelines are guidelines. These are just recommendations. You do not have to follow the guidelines. It's good to follow them, but of course we are all physicians and we always have the freedom to do it differently, and you did it differently.
We did.
You wanted to be on the safe side.
Yeah. So we proceeded to intervention in the left circumflex vessel. It was easy to wire. We had a single wire down the distal end of the second obtuse marginal branch, and we basically predilated the distal lesion and then deployed a long drug-eluting stent to cover all the disease in the distal circumflex, avoiding the obtuse marginal branch more proximally.
It looks like there's still a residual lesion at the marginal branch origin. Did you leave that, or?
Well, that's a good question. What we then did was we decided to try to keep it simple. A second stent would cover origin of marginal. We certainly didn't want to put overlap at the origin of marginal because we were concerned that we might cause compromise to the vessel. And you can see there that there's a small area of non-stented segment in the distal circumflex, but we still preserved TIMI3 flow into the obtuse marginal branch without any compromise. And you can see that area of myocardium is an important area of myocardium for the patient. It's the one area which doesn't have an occluded vessel going to it. So we then proceeded to LED.
Well, the LAD, we agreed on that, was the culprit lesion.
In fact, with a floppy wire, a little bit of manipulation and just gentle pressure, over a period of about 5 minutes, the wire went down. It didn't slip down quickly, but it took about 5 minutes to wire down into the distal LED, and we saw obviously that there was some restoration of flow in what was quite a small caliber vessel. And we also saw some improvement in flow in the large diagonal branch adjacent to the occluded segment.
I think that's important for the audience to know that maybe it's a good decision to start with a regular floppy wire in acute coronary syndrome if the vessel is occluded, and not with a polymer, and you don't know where you end up with this wire.
Exactly.
Yeah.
You don't know where you end up, and you can make it worse rather than better.
A one wire or two wire strategy in the LAD to protect the diagonal branch, or you just go straight and open the LAD with one wire?
So we ended up using one wire.
Yeah, I think for the audience, I think either decision is reasonable.
So again, we took a small long balloon down our LED, and we balloon dilated really quite distally and back up to where the occlusion was. And you can see that as a consequence of that, we do have slow flow now in the diagonal branch, but we have the benefit of distal LED picking up, a lot of vasoconstriction, but several septal branches picking up in the distal third of the LED. We've not compromised our proximal septal, which was of course a major concern, as this is going probably to a very reasonable sized area of septum, and perhaps also collateralizing the right coronary, which is helpful. So we took the view that if we did lose diagonal, what we wouldn't do was lose septal in the case. What we decided to do here was take two long drug-eluting stents and basically deploy them from distal LED to mid-LED in overlap. And he had quite a lot of spasm in the distal vessel. So we gave intracoronary nitrate, and at that point we then decided to insert an intra-aortic balloon pump.
Well, this is a good case, but I still think we should discuss the controversy between the guidelines on one side and your approach on the other side, because this is contradictory. Of course, you're free to do that, but we should look at this a little bit more detailed. The guidelines we have presented last year at the ESC in Stockholm had as a key point in the middle the heart team. And for non-STEMI, like in this case, we recommended to do the culprit lesion only without a big discussion with the surgeons or the heart team. But then, especially in this patient with an occluded right and a highly diseased circumflex and diabetes, the guidelines would recommend finish the culprit lesion and then discuss the further procedure in the heart team. Did you discuss this case with your surgeons at some stage, or?
We certainly told the surgeons of the case, and we did the procedure in the lab, and we saw what we had. Interestingly, it was occurring towards the end of the day, and we took the view that our surgeons would probably not want to do anything acutely here. They were uncertain about the LED. They often call an occluded LED a blind date, so when they don't know if they can get a decent graft on the LED, it does reduce their desire to do the procedure. So I think that if I did the case again, I think I may have done it differently.
Yeah. But I mean, because you could always say if you could not have opened the LAD, then the patient had to go to surgery anyway.
Yes.
But you opened up the LAD, so you were right.
He had sustained no decompensation with regards to his mitral valve function, and although it was a long admission, after 12 days he was well enough to be discharged. He was angina-free.
So Neil, congratulations to this great case. I mean, we say those who heal are right, and you were right in this case.
He was very well, and he has come back to Paris. We've sent all the information to his cardiologist there.
Well, thank you, Neil, and thanks to you, to the audience. And I think our point was to show you that medicine is not always that easy, and there are always different options to treat a case optimally. Thank you.